talking about risk factors for cardiometabolic diseases. And first I had a little homework assignment for you. Did you manage to find these different codes in the ICD-11 system? I see some people happy faces, like yes, we did. Because why did I do this exercise? You can check whether your answers are correct. It's BA41, 8B11, 5A11, GB61. Well, these codes, of course, are only meaningful for classification purposes. But I think it's also good for you to see that these diseases are in different types of categories. Like the myocardial infarction is in the circulatory system, but the ischemic stroke is in the nervous system. And diabetes is amongst the endocrine diseases, and here you have, for kidney disease, also another category. And the reason why I mention that is that this is also the way our healthcare is organized. So when you have myocardial infarction, you visit a cardiologist. But when you suffer a stroke, you will visit a neurologist. And that's quite interesting because when you know that the pathophysiology for many of these diseases is shared, and you go to a doctor that only studies one specific endpoint, he or she may miss out on other diseases that you could have. So it's the way our healthcare system is organized is not that much organized from a patient-centered point of view, but more from a medical discipline point of view. And there can be quite some barriers amongst these different disciplines. That's what I notice, at least. So I find it really interesting that somebody who suffers a stroke may not get dietary advice, while somebody who suffers a myocardial infarction does often get dietary advice. And so it's just good to realize that this is daily practice. So today we study main risk factors and explain differences between a risk factor and a risk marker, and also how these different risk factors could impact various cardiometabolic outcomes. I will tell a little bit about the causal pi model. You may remember that if you follow the Introduction to Epi course or some other courses maybe, but at least it's good to know that there is some causal thinking, causal inference that we use also in this field, and about the cardiovascular risk management. Somebody asked what to do with all these papers that are posted on Brightspace. So much information, also including that paper on cardiovascular risk management. It's the paper by the European Society of Cardiology. This is really a lengthy paper with a lot of details. We don't want you to study all of that. It's just for you important to know that the European Society of Cardiology has a guideline, has a statement on how to treat people with cardiometabolic risk. And that's when you want to know what kind of treatment to give, how important dietary advice is, when you have diabetes and myocardial infarction, what to do then, what kind of targets for lipid lowering, and so on. These are all in that specific paper from 2021. And you don't have to learn that by heart. Maybe some key figures that are mentioned in the clinical week for cutoff value for LDL cholesterol, for example, but not all these details. But have a look at these flowcharts in such a paper, so to get a feeling, what is this field doing? How do clinicians treat their patients? So it's also, I try to explain with every paper what is important, whether it's a key message or study in more detail, but mostly what's covered in the lectures. That is important for the exam, and the reading materials are for you to get further understanding, to check some details, to understand where the field is moving in research and in the clinic. If you have any specific questions, you can also ask later on during the course. We have some question hours, and let's just go through some of your questions if you have them. Okay? Okay, so this is our schedule for today. I also want to show you some important epidemiological studies in the field after the break, but let's just go through these different aspects. First, a question for you. Is cardiovascular disease a man's disease? What do you think? No? A lot of women in this audience?
No.
No. But it was thought earlier that, well, it's mainly men who died from heart attacks. So there is some history there. Huh? So how come that many people think it's a man's disease?
I think it's because like guys, they don't really have periods. And I mean, imagine sometimes like they don't deal with waste nicely. So yeah.
It's because they don't have their monthly periods.
No period.
And that also, these monthly periods could also give some complaints, symptoms, and mask any underlying disease. Is that what you mean? Or is it, what do you mean with, is the monthly period a risk factor or a protective factor? Or could you explain a little further?
I think like monthly period is like it's like something that lowers the risk because like when you still have period, it means that you still have estrogen.
Ah, okay.
And it means that your HDL is likely higher, so therefore less risk.
So you say women are a little bit protected against cardiovascular disease because of estrogen levels. Yeah, that's good. So it may be a man's disease then, or not? Well, let's just go. Well, there's another suggestion.
I thought back in the days that men used to smoke more than women.
Yeah, that's true. That's definitely one of the reasons why in the 1980s and 90s heart attacks mainly occurred in men. It's because of much higher smoking prevalence. Here you can see some recent, well, not too recent actually, it's 2020 figures in the Netherlands, and you can see that in women they have a lower risk of myocardial infarction, but a higher risk of stroke. And that's also part of cardiovascular disease. So it's the type of cardiovascular disease that differs. And you can see that overall, total CVD mortality doesn't really differ between men and women. So it's both a disease in men and women, but the types of cardiovascular disease, they differ to some extent. And also, what you see here is the biological age, and in blue is male and orange is female. And what you can see is that women get their cardiovascular disease later on in life. And that may have to do with your suggestion that estrogen maybe protects, so that the CVD mainly develops after menopause in women. So they catch up later actually, but still it's the most important cause of death in many countries, also in women. And there are many different hypotheses. This is a field of research. Maybe you are interested in this. There can be many reasons why it differs between men and women. It's also that women present themselves with symptoms that are different from those in men. And a lot of research has been based on male participants. So the symptoms may not be recognized well, and treatments may not be as effective in women as in men. And but there could also be other reasons. Pregnancy could be a protective factor, or gestational diabetes could be a risk factor, for example. And there's also social determinants. Psychological stress may have a different impact in women than in men. So there's all kinds of reasons why there are differences between men and women in cardiovascular disease. Any more ideas? I already told you that the diagnosis, so the presentation of symptoms may differ. So I gave the answer, I'm sorry to that. Mm-hmm. But that's also something that a doctor may not be aware, and a participant or a patient may not be aware that it could be cardiovascular disease. So I think men more often have pain in the upper arm or more pain, and women have more like stress-related, anxiety-related symptoms. So that's also part of the puzzle. Okay, so now we have gender as a risk factor or protective factor for cardiovascular disease, but there are many more potential factors. And I sometimes make a difference in endogenous factors. They are more from inside the body, intrinsic, and the exogenous factors, they come more from the environment. So things you can be exposed to or not, and these are more difficult to avoid. So there's all kind of ways to classify these risk factors. Stress can be endogenous or exogenous. I don't know, actually sleep is also a risk factor. Good sleep is a protective factor for cardiovascular disease. There's all kind of mechanisms that could explain that. So this is one way to classify risk factors. I prefer more this way of classification. There are non-modifiable factors and there are modifiable factors. This is more helpful for public health or for clinical strategies. There's all kinds of, the LDL cholesterol is important. There's all kinds of dietary lifestyle behaviors, but also stress, sleep, genetics, they play a role. They make people more susceptible to certain risk factors. Genetics alone in itself, this does not explain the largest part. I think less than 10% only of cardiovascular disease. But in interaction with the lifestyle factors and the environment, then of course, then the genes may become important because some people are more sensitive then to certain risk factors. I also often say that cardiovascular disease is 100% genetic and 100% environmental. It's both. It's almost always gene-nutrient interaction or gene-lifestyle interactions. Okay, so what have we got here? Yeah, so there's, when we look at these factors, for example, sedentary lifestyle and healthy eating, often they impact cardiovascular disease through different risk factors, like blood pressure goes up after eating salt, or your blood cholesterol goes up after eating saturated fat, body mass index after junk food or whatever you call it, and blood glucose after eating a lot of sugary beverages and drinking a lot of beverage. But there's also pathways that these risk factors directly impact the end organs. So therefore I also place an arrow here. Like when you smoke, you directly damage your vessel wall or your heart tissue or your brain tissue. So there's both through these what we call intermediate or intermediary factors. They are in the pathway from exposure to disease. But there can be also pathways that just directly impact the end organ. So salt intake can directly damage your kidney function, your kidney tissue. Well, there's another one. It's just to show you how complicated it is, because of course there's also determinants of your behavior. So is socioeconomic status, is that a risk factor or not? Yeah? So it's often a determinant of your food intake, of your lifestyle, of air pollution, for example. So there's also this layer, it just precedes all the other factors. And there's also early life exposures. It could be that salt intake of your mother had an impact on how your blood pressure regulation system is just generated in early life, and how your kidney function set points are influenced. And so early life exposures can be rather important. I don't say they are more important than later life exposures, but it's definitely also a thing to keep in mind. And there are some studies, for example, where they had starvation during the World War II, and these children were malnourished, and later on they appeared to have higher risk of diabetes. So there's what happens early in life, maybe even pre-pregnancy, is important for later life risk of diabetes and cardiovascular disease. So that's quite a big field of research, and I even don't know all of the answers. There's so much interaction between all these factors, and it's a tough job to disentangle these different factors when you do the research. There's also COVID. Infections can also play a role in cardiovascular health. Also, when you have your mouth hygiene, when you don't go to the dentist, you may also get a higher risk of cardiovascular disease because of bacteria and infections of the heart, and that can be quite serious, actually. Yes?
So on the slides, like the purple box seems to be like an indirect factor that not necessarily has to be against, right? Because it's not direct error, but
Yeah.
it can be also a direct cause, right?
It can also be direct to the clinical cardiovascular event. So if your heart is infected by a virus, then it goes directly to the clinical event. That's true. You are better than my gloves, so very good. Yeah. Okay. When we look at the cardiometabolic disease processes, of course that is a gradual process. So it starts with a healthy individual, and with healthy I mean ability to adapt to all kind of stresses without having a change in the phenotype. So of course your blood pressure goes up when you take the stairs, and then it goes down again. Your body is able to regulate it. But when your blood pressure stays higher, then there's some loss of function. So there's at some point you may not be able to adapt to certain, for example, when you eat Big Mac or something. You are still young, healthy. Salt intake is not that harmful now, but later on in life, your kidneys don't function well, and then salt starts raising your blood pressure. There can be early changes, and that will be discussed also in the week on molecular nutrition. They can measure already in the cells or in DNA expression what happens in the body with exposures to risk factors. Small abnormalities like a decrease in endothelial function that you don't even notice can already happen in the body, and they are still reversible, but at some point they are no longer reversible. And then you start having elevated risk factors that need to be treated, like high blood pressure, inflammation, like we had discussion on plaques, atherosclerotic plaques, and high cholesterol, loss of kidney function. At that phase, there can be screening. So then there might be screening programs at the doctor's office or maybe in the population to detect people at higher risk. But it's important to realize that it already starts here, and you want to be earlier. But when it's still reversible, screening is less effective. And so it's very difficult to determine when you should screen for certain risk factors. And then when you actually have the disease, when you get an event, when you are diagnosed with diabetes, then we call it the clinical phase. Then you come to the attention of a doctor, and then you need treatment. So this is of course related to age. But already at the age of 20, your blood pressure is higher than at younger age. So I think that even 2/3 of your lifelong increase in blood pressure takes place before the age of 30. And that has to do also with the high salt in our environment. So when you are at the age of 10, your blood pressure might be 90, the upper level. And then when you are 30, it might be 118 or something. That's a huge increase. And we say, well, that's normal. Your blood pressure goes up with age. But there are populations that live in a healthy environment that don't show that age-related increase in blood pressure. So already in early life, before the age of 30, a lot can be determined for your future risk of cardiovascular disease. And that's just because of our living environment that you cannot escape, unfortunately. Okay, I want to mention two relatively new pathways in cardiometabolic disease. We know about high cholesterol, we know about high blood pressure, but there's also a lot of research done on chronic low-grade inflammation. So adipose tissue generates a lot of inflammatory factors, and there's also factors released by the inner lining of your arteries, the endothelium. That's also an active organ that releases all kind of factors, like here the nitric oxide, and I will tell more about that in the molecular week. But just for you to know now that there's a lot of biomarkers, a lot of substances in your blood that tell something about your inflammatory status and about your endothelial function. So, and this is studied quite a lot nowadays because there's also a shift towards more molecular work in the cardiometabolic field. Metabolomics, proteomics, all the omics stuff that you will hear about also in this course. And the inflammation may also be an underlying disease process for many other chronic diseases. So also for cancer, for gastrointestinal health, and inflammation is a bit of a buzzword now in scientific research. I think you have heard about it already in other courses probably. The cardiovascular risk factors don't only affect your heart and blood vessels, but also the brain. And so the vascular risk factors are important for dementia, for example. If people ask you how to prevent dementia, then nowadays it's more and more important to realize that vascular health is very important. Lowering blood pressure, prevention of atherosclerosis, and all that kind of. But also the blood vessels in the eye, in the nervous system can be affected by poor cardiovascular health. So it's cardiovascular blood pressure is really an important risk factor, and I think also the inflammation related to poor lifestyle. Is there any questions until now of what I've told? Is that clear to you? Any? Yes?
Just a question about the previous slide.
Yeah.
It says vasodilation goes down.
Yeah.
But I'm a bit confused because I thought it always went up or something.
No, vasodilation is a good thing. So that your vessels are able to dilate. When there's increased blood flow, they should be dilating. If that goes down, it's a sign of vascular damage. So it's not good. And I don't know if anybody of you is a smoker. I can immediately see that when I do the vascular function measurement, because the endothelial function is very much impacted by smoking. The NO production and the vasodilation is really impaired, also in young people when they smoke. It's not to make you anxious, but it's good to stop smoking, obviously. Okay, so which CVD risk factor is the main contributor to mortality worldwide? What do you think? Is it obesity? Is it smoking? Is it cholesterol? I think blood pressure. Who votes for A? 4 people. Good. Who votes for B? No cholesterol fancy. Okay. And the obesity problem. Yeah, quite some people say obesity. Yeah. Who thinks smoking is the also? It's equally distributed over ABD. Oh no, ACD. Okay. Well, it is actually blood pressure. And why is it not smoking? Well, smoking is the strongest risk factor, but smoking is not prevalent in every person. So you always have to, when you think what has the largest impact, you must think of the strength of the risk factor plus the amount of people exposed to that specific factor. So the two together determine the burden of disease. So something can be really, really risky, but if only 1% of the population is exposed, then it doesn't contribute a lot to the global burden of disease. Well, everybody is exposed to blood pressure, and even small increases have an impact on a population level in the amount of cardiovascular events. You can see here also a diet. They are ranked a little bit lower, and I don't like actually this study, even though it's a hallmark study and really important, because diet, of course, also works through these risk factors. So it's not, in my view, not fair to take away this impact from the diet part. This is only the contribution of diet apart from these risk factors. Like I showed you, there are intermediary factors. These are all intermediary factors for the diet-disease relationship. So actually, I think the impact of diet is much larger than shown in this graph. But blood pressure worldwide has been recognized as the main contributor to cardiovascular disease mortality, and DALYs as well. And they have another, like they use this classification for the different risk factors. That's also possible. I don't have, there's no exam question which is the best possible classification of risk factors. It's just for you to realize that we need some system to be able to work with all these different factors. And I've now shown you 3 different systems which all have their pros and cons. So let's start with blood pressure.